So today we're going to be talking about early puberty. Okay. So we are going to start our discussion by defining early puberty. We're going to talk a little bit about timing and what is considered normal. I do want to make sure we are able to differentiate between normal puberty variants and disordered puberty, and then we're going to talk a little bit about treatment and then a more individualized approach about treatment of early puberty and more specifically of central precocious puberty. So when we're talking about puberty, this is a process that leads to physical, sexual, and psychosocial maturation. So what is happening through puberty is we have the gonadal maturation, and that is after the stimulation from the gonadotropes from our pituitary. Then we have the production of sex steroids, so estrogen and testosterone. So we see the development of secondary sexual characteristics. We have the adolescent growth spurt. We have attainment of fertility, and then a lot of psychosocial changes. Now, there are specific events that are happening during puberty, and the two main events is the gonadarche, which that refers to the activation of the gonads, so again, testicles or ovaries from our pituitary, and that will lead to breast development as the first sign of puberty in girls and testicular enlargement as the first sign of puberty in boys. And then we have a separate process, which is the adrenarche, which is the activation of the adrenal glands. So for that, we have the pubic hair, the armpit hair, the body odor, the acne. Oftentimes, when we're talking about puberty, we refer to those two together, and most of the times they're happening close to the same time. But when we're talking about early puberty or delayed puberty, we are referring mostly to the gonadarche. Now, there are other terms that we're using to describe more specific parts of puberty. So thelarche, for example, is the appearance of breast tissue due to the action of the estrogen. Menarche is the first menstrual bleed, which again, in the very beginning, they're anovulatory. Spermarche is the time of the first sperm production, and then puberche is the appearance only of the pubic hair, although many times when we're using that term, we're referring pretty much to all the events that are happening during adrenarche. Now, in terms of anatomy, there are a couple of different sides that they are involved in puberty. So first is the hypothalamus, then the anterior pituitary gland, and then, of course, the gonads, which can be either ovary or testicle. So things start from the hypothalamus, which we have a pulsatile release of the GnRH from the arcuate nucleus of the hypothalamus. Then that will go down in the anterior pituitary and will stimulate the release of LH and FSH. In the very beginning of puberty, we have more of a diurnal secretion of the LH. So most of the LH is being secreted overnight while we're sleeping, very little during the daytime. And then as puberty progresses, we see more persistence of that LH during the daytime as well. And then if we have an ovary, the FSH will go down, will stimulate the follicles, and with the LH will stimulate the granulosa cells to produce the estrogen. So in the very beginning, again, we're going to see the breast development. That estrogen also will act in the growth plates in the skeleton, so will reduce the skeletal maturation and the pubertal spurt. And eventually, as we progress, they fuse the growth plates, so we're going to stop growing. And then you see kind of the inhibitory feedback, all those hormones are acting back in the pituitary and in the hypothalamus to modulate or regulate the release of those hormones. And then finally, as we progress through puberty, the LH, along with the estrogen and progesterone, will regulate our menstrual cycles. It takes about 2.5 years for those cycles to get mature in order for us to have more regular ovulation. Now, if we have testicles, the FSH will go down to the seminiferous tubules. They will induce their growth, so we have increase in testicular size. They will act on the Sertoli cells, and then we'll have the production of inhibin B, which will regulate, again, the production of LH and FSH. The LH will go down to the Leydig cells, so we have the production of the testosterone. So things that we see is increase in muscle mass, increase in penile growth, deepening of the voice, hair growth, and then some of that testosterone will convert to estrogen. So again, we see the same effect with the pubertal growth spurt. Then we have local production of testosterone in the testicles, which will increase again the maturation and size of the seminiferous tubule, so there is increase in testicular size. Now, how all those things start, how the puberty and the release of those hormones starts. So we understand that this is a very complicated process, and there are still things that we'll keep learning as to how this is happening. We know that there are certain events that they're stimulatory and others that they're inhibitory in terms of puberty. For example, we understand that kisspeptin, which is a peptide that comes in the preoptic area of the nucleus, arcuate nucleus in the hypothalamus, is one of the more potent stimulus for puberty. So kisspeptin will be secreted from the neurons and then will go down in the receptor and stimulate the pulsatile release of the GnRH. Now we keep learning about more peptides, so those are more recent described, the MKRN3 and the DLK1, which we think that they're acting more as a break in the puberty, so they're higher, we see higher amounts of those peptides during prepubertal years, and then again they decrease during puberty, so we can have the release of the GnRH. Now, just a couple of milestones that are happening during puberty. So if we have somebody that has ovaries, breast development will start at the age, most of the times between the ages of 8 of 13, right? That's the first sign of puberty, and really is a surrogate marker of ovarian enlargement. That's the true first sign of puberty in girls. You see here that periods are going to start about 2 or 2.5 years after the first breast development. Is not typically around, the mean age is around the age of 12 or 12.5. And then here is the growth spurt. So you can see that the growth spurt can start even before the first sign is obvious to us, so even before we see the first breast buds, and then the peak of that growth spurt happens very early in girls, so a late stage 2 or early stage 3. Now in boys it's a little bit different. So we have again testicular enlargement, typically between the ages of 9.5 and 13.5. Pubic hair typically are happening a little bit later. But one of the things I wanted to see that the growth spurt also is later. So the time that the growth spurt will start is when boys are well into puberty, right? So they're standard stage 3, and then their peak growth spurt is happening quite later, close to early standard stage 5. Now let's talk about some normal variants of early puberty. So one is the premature thelocare or idiopathic premature thelocare. So this is the development of only breast tissue, no other signs of puberty, no other secondary sexual characteristics. And this is, of course, the definition is before the age of 8 years. Most of the times we see that around the age of 2 or before the age of 2. More common age is 3 to 12 months. Again, it's only breast development. Sometimes can be unilateral, which can be quite concerning to parents. We don't have any other signs. We typically don't see a growth spurt. If we're going to get a bone age, that will be normal or near normal. And really, we don't need to be doing an excessive workup with those kids, but we do need to follow up very closely. Most of the times, actually, the breast will stay the same. About 60% of the times, it will have no progression, but will not regress much either. But then there is a 5% that will progress to early puberty. So again, reassurance to the parents, but also let them know that you need to keep an eye on that. Now, one of the things to pay attention, if we end up getting labs in those kids, looking into LH and estradiol, we really have to be careful how we're interpreting those labs, because up until the age of 3, we may still be seeing the mini puberty of infancy. So that means that those might be elevated in the early pubertal range. So that doesn't mean the kid is in central precocious puberty. So we have to be careful so we don't misdiagnose those kids. So we'll look into other surrogate markers again. What is your bone age doing, your growth velocity, pace of progression, and your all very important.
Because we do see a lot of kids.
Yeah.
I don't know if it's more common in the African American population, but we have a lot of kids. At what point would you say to even get a bone age? Because I do watch a lot of them clinically before even, going to that point.
Yeah, only if there is progression. So if you see that, the breast development is progressing, or you see other signs of early puberty, like fast growth pace, if you see more estrogen effect in the vaginal mucosa, then I will get the bone age. Other than that, it's just clinical follow-up.
Okay.
Yep.
Thank
Now, premature adrenarche, so this is the appearance of the adrenarche signs, so pubic hair, armpit hair, body odor, without breast development in girls before the age of 8, and without testicular enlargement in boys before the age of 9. Typically, with premature adrenarche, there is no virilization, right? So we're not going to see clitoromegaly, for example. We're not going to see increase in penile length or deepening of the voice in boys. And this is associated with earlier production of DHA sulfate from our adrenal glands. We see that more commonly in females. We also see that more commonly in children that they have obesity or insulin resistance, and also is related with prematurity as well, especially those very low birth weight babies that they then proceed to have a fast postnatal growth. We understand that might be associated with insulin resistance going back here as well, or metabolic trouble. So we see high rates of premature adrenarche in that population. If we end up getting a bone age, then there is typically mild advancement, although there have been cases that we see a little bit more of advancement there. Again, we have to take other things under consideration. For example, obesity might be contributing to such advancement as well. But then we have to be mindful, because there might be some pathology behind early adrenarche, right? So about 4% of kids that they will present with early adrenarche will have non-classic or late onset CAH, congenital adrenal hyperplasia. So things that can be red flags for you if there is rapid progression of those signs, if you see a more pronounced growth spurt, and then again, if your bone age is significantly advanced, then you want to do more of an evaluation. And we typically start with morning 17-hydroxyprogesterone to again, screen for CAH. Now, one of the things that I counsel the families is that can be idiopathic early adrenarche can be related with polycystic ovary syndrome. So that's for families with girls to keep that in mind, and then also with metabolic syndrome later in life. Now, isolated pubic hair of infancy, so sometimes we see those babies that they will have those fine genital hair. Again, they're finer in texture. They're located typically in the labia or in the scrotum, not in the pubic symphysis where we see the hair coming when we have real adrenarche. So typically this is transient. Many times the hair actually will go away. And if there is no progressive development, you do not see any other signs of adrenarche or puberty, really you don't need to do any evaluations, just guidance, anticipatory guidance, and follow up those kids. Benign prepubertal vaginal bleeding. So sometimes we see, it's quite rare, but we see girls presenting with the first menstrual bleed without any other signs of puberty. So they do not have any breast development. They do not have any signs of adrenarche. We're not sure why this is happening. Speculations are that may have some increased sensitivity in the endometrium to the estrogens, or there might be some transient stimulation of the HPG axis. If if we get a pelvic ultrasound that is normal, if we get LH, FSH, and estradiol, those are normal and prepubertal. But we have to keep in mind other sources of vaginal bleeding. So we have to make sure there is no vaginal trauma, there is no infection, sexual abuse. And then if you have somebody that they keep having those episodes, right, we have to keep in mind also other sources. So ovarian cyst, for example, can cause that. As the ovarian cyst regresses and the estrogen go down, we may see that menstrual bleed. And that's important to figure out, although sometimes it can be challenging, because that can be part of Mycunal-Bright syndrome, right? So we have to keep that in mind as well. Now, sometimes we have patients, especially girls, that are presenting with all the signs of precocious puberty. So they will have breast development, they will have some acceleration in their growth spurt initially. They may or may not have signs of adrenarche, and then they stop. They either don't progress or they progress very slowly. So we classify that as non-progressing or intermittently progressive precocious puberty. Their bone age typically is normal or slightly advanced. If we're going to do LH and estradiol, they're in the very early pubertal range, or sometimes they're prepubertal. So those kids, we still need to follow very, very closely, but we don't necessarily need to do anything in terms of treatment, because most of them, they will end up having very slow progression of their puberty. They will have menarche at a regular age, and then they will not have any effect in their adult height. So when do you refer, right? When you see all those variants, when do you refer for further evaluation to a specialist? So first, depends on your comfort level on following those kids. But then there are some red flags that you need to keep in mind, right? So if there's vaginal bleeding, I would say it's a good idea to refer. If you see growth acceleration, really advancement of the bone age, or if you see other signs of virilization, clitoromegaly, increase in penile length, then you really want to refer for further evaluation. Now, I want to talk a little bit about what we consider normal in terms of timing of puberty, right? So we're still using, in terms of puberty in girls, the cutoffs of 8 as being the earliest and 13 being the latest, that it's okay to see pubertal onset in girls, and then 9 and 14 in boys. And that was based on a series published from Tanner and Marshall. And what they did is they took pictures of girls in UK every 3 months and boys, and then they rated their breast development and pubic hair development and their testicular development and pubic hair development in boys. Then we have other studies that are being done in US after that they pretty much confirmed those ranges in terms of what is considered to be normal in puberty. But then over the last several years, we keep kind of asking the question, is puberty starting earlier? And we are more concerned or seeing that more in girls. So that was a panel looked into several studies done between 1940 and 1994. And they concluded that based on the data, they did see earlier age of breast development and earlier age of menarche. There are subsequent studies being done after that looking at the breast cancer and environmental research program. They did note further increase in age of breast development, but they didn't see as much change in age of menarche. And then this is the most recent review looking into international studies between 1977 and 2013, and they did also find a trend towards early toddlercare, and they classify that as decreasing by 3 months per decade. So then the question is why this is happening, why we might see puberty starting earlier. So over the last decade or so, we are recognizing a little bit more the endocrine disruptors, right? So those are chemicals that we believe they are associated with changes in our hormones, or they can affect also pubertal development. So an endocrine disruptive chemical, or EDC, is defined as an exogenous chemical or mixture of chemicals that interferes with any aspect of our hormone action. So that could be either synthesis of our hormones, secretion, transport, binding, action, or really elimination of the hormones. And then you can see here that you can find those chemicals in everyday household items, plastic, pesticides. And then we also look into kind of what we classify as essential or natural oils, right? So tea tree oil, for example, and lavender oil, which we use quite commonly, they can act as phytoestrogens in our body. Now, there are some data looking into specifically the effect of the EDC exposure to puberty, right? If there is a raise, there is an impact in early puberty. There are though few studies that really have the statistical power to examine the interaction. But again, we have some data. So for example, they have seen higher serum levels of phthalates in girls with Puerto Rico that they came with premature toddlercare. They have seen higher plasma levels of DDE, which is a metabolite of DDT that is used in pesticides, in immigrant girls in Belgium with sexual precocity. And there are many animal models that they're looking into that, and they recognize that EDCs might be impacting puberty through epigenetic mechanisms. That was actually an interesting poster that I saw in. That was in the European Society for Pediatric Endocrinology. That was the most recent conference. And their question was, is black light, the blue light, actually interfering with our hormones, right? What they did is they looked into rats, they exposed them to blue light, and then they actually did see that puberty did occur significantly earlier in the groups that they were exposed, and the longer the duration of exposure, the earlier the onset of puberty. And also they measure hormones. So they saw a decrease in melatonin, they saw an increase in LH and estradiol, and then the physical changes of puberty. Again, this is in rats, this is not in human, right? You cannot really mimic exactly the same exposure in blue light that a toddler or a child will get from a smartphone or a tablet. But then if you look into puberty of rats, it's actually very similar with our puberty, and then the stages are very similar to ours. So it really raises the question, right? So we'll be looking into that more now that everybody is exposed to blue light.
And can you block it if you block the light?
That's a good question, right? Yeah, if you, what happens if you do that?
Or whatever.
Yeah, so we really need to be looking at that, right? Because we have all those kids all the time. So I'm hoping that will trigger more, research in this area. The other question is, how about BMI and obesity? How might be interfering with early puberty or earlier onset of puberty? We understand that in phenotypic observational studies, BMI can account for a big proportion of variability in pubertal onset. There are several evidence. Again, we understand that there is increase in obesity overall, and that correlates with increase in rise in central precocious puberty. And then we do have epidemiological cross-sectional and longitudinal studies looking into earlier set of puberty in girls that they present with obesity. So how that might be happening? So we understand that adiponectin overall might be related. So leptin, for example, can stimulate the production of kisspeptin. And remember, we're discussing that kisspeptin is one of the really strong stimulant for the release of GnRH. Kisspeptin goes up in obesity and is being produced by the fat tissue. Adiponectin inhibits kisspeptin, and what we see when we have obesity is that adiponectin goes down. So there are several mechanisms that can be have been proposed that correlate obesity and earlier puberty. Small for gestational age, so we do see also earlier timing in kids that they have been born with small for gestational age. We also see, remember we talked about that a little bit before, those kids sometimes they have a rapid postnatal weight that can lead to earlier production of adrenal androgen and earlier onset of puberty. We also see more accelerated bone maturation in those kids, and also the peak of height velocity is happening earlier in puberty. And they also have shorter duration of pubertal growth. So the question is, we do see increasing rate of SGA, is that correlating with the increasing rates of earlier puberty that we're seeing? Of course, there are genetic influence as well. We have many genetic mutations that we have identified in different peptides that are involved with the initiation of puberty. There is no commercial lab for us to test all those, but might be in the future. And then although we understand that onset of puberty can be multifactorial, right? From twin studies, heritability has been accountable for about 57 to 61% of the variation in age at menarche and about 91% of the variation in onset of pubertal growth spurt. Now, back in 1997, the Pediatric Research in Office Setting Network started to put race into the discussion about timing of puberty. So this is a very large cross-sectional studies. They had about 70,000 girls that they were seeing in about 65 mainly suburban pediatric offices, and they looked into their pubertal development. Girls that they were eligible to participate were either girls that they were having a wild child sex, so they had Tanner staging done, or they were there for a trouble that they needed a full physical evaluation. So what they found was that black girls at every age had more advanced breast development compared to white girls. Breast development had begun at the age of 6 years for 6.4% of black and 2.8% of white girls, and by 8 years in 37.8% of black and 10.5% in white girls. Again, earlier ages. So at that point, the Pediatric Endocrine Society Drug and Therapeutic Committee used those findings to introduce new guidelines that they were race-based in terms of how we define early puberty. So they proposed that we should be considering early puberty 6 years of age in black girls and before the age of 7 in white girls. Now, although these guidelines were never formally recognized and we're not using them, race became widely accepted as a factor of pubertal timing in girls, and we see actually reports from the American Academy of Pediatrics or guidelines from Pediatric Endocrine Society that they're using that. So as a result, we have many patients or maybe caregivers or medical students, physicians, that they have been told that black girls experience puberty at earlier ages. When we're looking, though, into genetic ancestry and timing of puberty, there has been some association reported, but the correlation is relatively weak and is not observed in all population groups, and also will decrease when there is more diversification. Moreover, if we see, when we're talking about race and ethnic groups, right, those represent a social contrast, right? And oftentimes we understand that it's a poor surrogate of genetic ancestry. So then it becomes the question, to what degree race and ethnicity is independent modifier as opposed to a marker of other factors that might be impacting pubertal timing, factors that we discussed before, for example, BMI or exposure to endocrine disruptor chemicals or other social determinants of health. So I think it's very important as we're looking into puberty, right, to keep in mind that if we have the bias that black girls will always start puberty earlier, are we missing girls? Are we not sending girls for evaluation? Do we delay their diagnosis and their treatment? Now, moving forward, who needs to be evaluated, right? Again, we still use the 8 years in females for all females and 9 years for all males, independent of their race or ethnicity or their BMI. Now, in terms of how extensive your evaluation is going to be, you don't always need to be very, doing all the lab that is out of the sun, especially in girls that may presenting a little bit later, 7 to 8 years of age. Again, those might be the girls that are going to progress very slow. You still need to monitor very, very closely, but you may not need to do a ton of laboratory tests. Things to pay attention on is the degree and rate of pubertal progression. So Tanner staging is very important. Having them come back for follow-up, not in a year, but in 3 to 4 months interval is very important. And also to establish the growth velocity, how fast they're growing. Again, our physical examination, and as I always say to medical students and residents, you cannot do Tanner staging without palpating breast, right? That's the only way, and then you have to quantify testicular volume too. Where it says the pubertal progression, again, if you have somebody that they're skipping Tanner stages every 3 to 4 months, it's very fast progression, so you need to be more worried. And then growth velocity, if they're growing more than 6 centimeters per year, that's fast progression for somebody that is not supposed to be in puberty. Bone age is a very useful tool, so that's an x-ray that we do of the left hand, and it gives us a little bit of information as to how long those steroids have been acting in our body and where we're heading to. So for example, if you have a bone age that is within 2 standard deviation of the chronological age, either you have a shorter duration of onset of puberty, or you have a puberty that is not going to progress very fast. It's kind of, stopped. So you can monitor those kids clinically, but if you have somebody with that bone age that is more, that 2 standard deviation advanced, then you have to be more suspicious, and those kids need more evaluation. So what do we get in terms of labs? So early morning LH and estradiol or testosterone is a good start. Early morning is very important. Remember, there is a diurnal variation of the LH in the very beginning of puberty. So if you do those tests, let's say in the afternoon, you may not be catching the peak of the hormones, although there is already activation of the gland. The assays that you're using are also very important. So there is actually pediatric assay in both LabCorp and Quest, and there is sensitive estradiol in both LabCorp and Quest. That's important because they can go to lower levels of those hormones. So sometimes we may need to be able to pick that early pubertal onset, and you cannot do with the adult assays. Now,
So the peak LH is in the early morning, so
correct.
Before 8 o'clock?
Yeah, so I typically ask them to be at the lab no later than 8 a.m. That's what I put in my instructions. Now, sometimes we have kids that we clinically understand that they're progressing through puberty. We have established that in our physical examination. We see their bone age advancing, but we do the test and we don't get the peak of the LH on the estradiol. So we can do a GnRH stimulation test. And the premise behind that is if you have a prepubertal child that they have not been primed in their own GnRH, giving them GnRH is not going to induce a big change in their LH and estradiol. But if they have already been primed by their own endogenous GnRH, giving that GnRH analog will really suit up the LH and subsequently the estradiol or testosterone. Now, if you do confirm that, those children are in puberty and the puberty starts from up in the pituitary, you want to look into the gland, so we do an MRI of the pituitary. Most of the times in girls, that is going to be normal, but in boys, we're a little bit more suspicious. So this is definitely something we don't want to miss doing in a boy presenting with early puberty. If you're concerned about thyroid malfunction or hypothyroidism, then you want to do your thyroid function test. That's quite rare. I haven't seen only one patient presenting with early puberty being profound hypothyroid, and typically that will reverse after you start thyroid hormone supplementation and puberty will stop. The thought behind that is that the very high TSH will interfere with the receptors of the FSH because FSH and TSH, they share the same alpha subunit. Pelvic ultrasonography is also a good tool. We can measure actually the size of the uterus, the size of the ovaries, and there are certain cutoffs we use to understand if this is a prepubertal or pubertal ovary or uterus. If you are concerned that puberty starts from the ovary, then we want to make sure there are not an ovarian cyst there or a mass that might be producing estrogen. Now, if you have somebody presenting with only adrenarche signs, we want to look into the adrenal gland function, right? So you want to exclude the CAH or more rarely an adrenal tumor. So 7-hydroxyprogesterone, D8 sulfate, androstenedione, and testosterone. If you're concerned based on those results, there might be adrenal tumor or a testosterone-producing tumor, you want to do an MRI of the abdomen and pelvis. If in your exam you're concerned about testicular enlargement or testicles are asymmetric in your exam, you want to keep in mind possible testicular tumors, so we can do a testicular ultrasound. And in boys specifically, you have to keep in mind also HCG-secreting tumors like cell tumors that they can present typically with some increase in testicular size and then also penile enlargement and other signs of the early adrenarche. Now, that's just quickly to go through, how we can think about during all those tests if you have somebody presenting in your clinic. So this is for somebody that has ovaries, so if they present with early breast development with or other signs of adrenarche, the first thing again is to do that, apart from your examination, apart from, looking into pace of advancement, you want to look into your bone age. So if your bone age is advanced, then you want to look into the hormones, right? So if both LH and estradiol are increased, it means that everything starts from the pituitary. So this is central precocious puberty, and the next step is to look into their MRI. If you have an increase, elevated estradiol, but your LH is suppressed, is low, then that means that things are starting down from the ovary, what we call peripheral precocious puberty. So you want to look into a pelvic ultrasound. And then if you have, normal LH and early breast development, the FSH actually can be a little bit more pronounced in those individuals. That might be non-progressive early puberty. So you just want to make sure that you continue to follow those kids. The same if you have the breast development, but either you have normal bone age or you don't have any further acceleration of growth velocity, and then maybe a bone age that's close to normal. That can be a normal variant of puberty, so you want to continue to monitor very closely. And then if you have adrenarche signs like pubic hair development, but you don't have central puberty signs like breast development, then you want to look into your adrenal glands and screen for possible CAH. Now, if you have somebody that has testicles, again, if you see early signs of puberty, the one thing that you want to do to establish is where is your testicular size, right? So if this is pubertal, above or equal or above 4 cc, you're going to look in your bone age. If that is advanced, again, you're looking into your hormones. If LH and testosterone are elevated, this is central precocious puberty, so you want to get that MRI. If your LH is low and your testosterone is elevated, that's peripheral, so it starts down in the testicles. And DNA rate stimulation test, sometimes can help us differentiate that a little bit more if we're not sure if this is kind of a true change or we couldn't get the peak of the LH. But if we establish that things are starting from the testicles, we want to make sure there is no mass there causing production of testosterone. There is something that's called familial testotoxicosis, which we have independent stimulation of the LH receptor in the testicles without coming from the hypothalamus. Typically, we have other family members having the same, so the family history is there. And typically those kids, they will present with more pronounced penile enlargement rather than testicular enlargement. And then if you have, we always get HCG in boys that present with early puberty, so if that's elevated, of course, you want to look for the source of that. Now, if you have somebody that they have some increased testicular size, but the bone age is not advanced, again, that might be a normal variant, so you want to make sure your follow-up with them. Again, the follow-up means you're coming them back in 3 to 4 months intervals. And then if your testicular size is prepubertal, but you see the other signs of adrenarche, again, you do your bone age. If this is advanced, you want to look for possible trouble with the adrenal glands. So if your 7-hydroxyprogesterone is elevated, you're suspicious for CAH. If your testosterone is elevated, but the rest of the adrenal androgens are low, then you want to look into a testosterone-producing tumor or an adrenal tumor that may be producing testosterone. So again, do your pelvic and abdominal MRI, and then keep in mind exogenous testosterone exposure. So who else in the family might be using testosterone? And then if you have normal androgens, the only one that might be elevated is the D8 sulfate. And I say elevated for the chronological age, but normal for the Tanner staging. That is premature adrenarche, and again, we just follow clinically those kids. Now, how about treatment of central precocious puberty? So our goal in central precocious puberty is to block the secretions of the gonadotroph, so block LH, FSH, so there is no more stimulation of the gonads, and then the estrogen and testosterone will slow down. So we do that by using GnRH agonists. So the way those medications work is that they provide a continuous stimulus in the pituitary, so that will lead to desensitization of those receptors. Remember, puberty is happening with the pulsatile release of those hormones, not continuous release of those hormones. Then we have, again, decrease of the sex steroids, so puberty will stop. We'll not see reversal of the pubertal signs that you already have. We may see some decrease, in the breast size or softening of the tissue, some decrease in testicular size, but that's it. But you still see kind of, a stop in further pubertal development.
What would the growth chart? How would that change?
Yes, that's a very good question. So what we typically see is slowdown of the pace of growth, right? So you're not going to see anymore the fast pace of growth, the growth spurt that you were seeing. And sometimes we even see those kids dropping a little bit from their line in the growth chart because there's a little bit more slowdown in the growth. Also, some of those kids are being treated until the age of 11 or 12, right? So if you see the growth chart, it takes into account that everybody will go through growth spurt at the same time. So at that time, the growth chart goes a little bit faster. Those kids know they're not in puberty because we're stopping that, so it seems that they're falling a little bit behind. But overall, again, you expect that the pace of the growth will slow down, and that's one of the markers we're using to figure out, the medications are working. Now, what type of medications we use? There are several now options that we have. When I started fellowship, there were only 2, but now we have more. So Lupron is approved since 2009, and it's an IM injection, which is every 3 months. Suprelin is an implant that we change every 12 months, so once a year, and is in the market since 2007. Triptogir was approved in 2017. It's an IM injection, which is every 6 months, so only 2 injections a year. And then Fezolvi is Luprolide as well, but is a depot subcutaneous injection, and is every 6 months. That was approved in 2020. Now, how about safety of those medications? Overall, they're quite safe. So some topical effects or short-term effects, we may have pain or local reaction in the injection site. Some of those kids, they get just a bump underneath the injection site that will go away in a week or so. Very rarely we see sterile abscess formation with the implant. If that stays, especially if that stays beyond the year, so closer to 2 years or more, there is the trouble of that breaking as you're trying to remove that. Hypersensitivity reactions are quite rare. Pseudotumor cerebri is actually a very new addition to the warning box by the FDA. So that was added in July of 2022, so very, very recent. And that was based in about 6 cases that they reported pseudotumor cerebri. They were treated with GnRH analogs. 5 of those were for early puberty, and 1 was for transgender care. So we're not sure, about the causation, but the FDA, does advise to monitor for pseudotumor cerebri signs and symptoms in kids that they are being treated with those analogs. The prolonged QT interval, that came along because this is something that has been seen in men that they're treated with GnRH analog, that they have prostate cancer. We are not sure if that is being seen in kids, so we still have to establish how frequent that complication is happening in kids. What the recommendations have been from our endocrine society is to only do an EKG in kids that they might have another reason or another risk factor for prolonged Q2. So either a family history of prolonged Q2 or a heart condition, or if there are other medications that can prolong the Q2. So in those kids, you want to get an EKG before you start the analogs, and then when you get in a steady state with your treatment. Now, in terms of long-term effects, we understand that GnRH analogs are quite safe and reversible. So things that we have looked into is how about gonadal function after we discontinue treatment and fertility. We haven't seen any change in both boys and girls. We haven't seen any increased incidence of menstrual disorders after using the analogs. The other question has been if those treatments are causing obesity or increased weight gain. We understand that obesity is related with early puberty, but we haven't seen those analogs causing that weight gain. The other question is how about the effect in our bone mineral density? During treatment, the bone mineral density would drop from the baseline, but we haven't seen that effect being sustained after discontinuation of treatment. The bone mineral density goes back to normal, and we don't see any troubles with the peak accrual levels of the bone mineral density moving forward. And then the other question has been kids that they have been treated with, or girls that they have been treated with GnRH analogs, do they have high rates of polycystic ovary syndrome? We do not think that the GnRH analogs is causing that, but remember, we're talking about early adrenochrome that might have to do with higher incidence of PCOS, and a lot of kids that they will present with early central puberty will have also signs of early adrenochrome. Now, looking into why we should consider starting those treatments, what are our goals? What is the outcome that we hope for? So one is to preserve the height potential of those individuals. So if they're going through that growth spurt early, they're also going to fuse the growth spurt early, and they may lose some of their height potential. I'm going to talk a little bit more about that in a minute. But the other goal is to relieve psychosocial stress, right? So there have been a discussion about how early menses or early pubertal development might be causing worry about pubertal development, such as the menstruation or sexuality. We have observed that kids that they have early puberty, they may have more frequent mood swings or emotional ability and irritability that can interfere with peer relationships or relationships within the house. And then the physical changes of puberty, they may cause feelings of shame or embarrassment or frustration. So that can lead to more insecurity, isolation, again, more troubles in terms of peer relationships. Now, the trouble we have is that we don't have a lot of data looking into that, and they have been somewhat conflicted. So we have a study that looked into 19 females with central precocious puberty prior to treatment initiation and found no difference in psychological distress as compared with females with normal puberty. There was another study that looked into 10 females with central precocious puberty that they did so reduce stress after starting GnRH analog therapy, so after having their puberty suppressed. And then another study, they looked into 36 females with central precocious puberty that they did demonstrate improvement in psychological scores, but that was irrespective if they were treated or not. So again, those are difficult studies to do. One of the things that I always say is, just talk with the family, see what their thoughts are, how that is affecting their child, how it's affecting overall the family functioning, so you can further decide what will be the best move moving forward. Now, how about height preservation? So we understand if we have children that are presenting at a younger age with early puberty and those that they have more of a rapid progression, those are the individuals that are going to benefit the most from those treatments. If we have females that they have onset of central precocious puberty before the age of 6 years, we anticipate an average gain of adult height of 9 to 10 centimeters. Whereas if you have somebody starting with puberty between the age of 6 and 8, then the anticipated gain is about 4 to 7 centimeters. Also, you have to take into consideration, of course, how advanced the bone age was at the time of treatment. So that can play a big role in the outcome. We still, though, keep having a lot of questions as to what is the latest time that we can start those treatments, or until when do we continue to treat, right? So far, we had in mind that, if you have somebody coming to your office with early puberty, right, have started with early puberty, but they present to your office after the age of 7, we have been a little bit more conservative of treating those kids. And then typically we end up our treatment when their bone age is closer to 12 years of age. So that was a recent study from 2021 trying to answer some of those questions. They looked into 48 girls with central precocious puberty that they were treated with monthly leuprolide depot. And their question was, what is the change in predicted height when you compare girls that the treatment was initiated before the age of 7 or after the age of 7. Again, all those girls have presented with early puberty. And then what is the difference if you stop that treatment before the bone age is 12 or after your bone age is 12? So they did see a lot of variation, but they, in terms of the outcome, but they did end up looking into about 5 to 10 centimeter height gain, even in kids that they were started on those treatments after the age of 7. They also see continuing increase in predicted adult height if they treated beyond chronological age of 10 or bone age of 12. So they concluded that predicted adult height improved in most girls, even if you start treatment after the age of 7, that most girls, they have reached actually adult height similar to the predicted height when the treatment was concluded, and then the predicted adult height continued to increase in most girls even when the treatment went beyond a bone age of 12 years. They also wanted to highlight that they couldn't find an absolute bone age or chronological age criteria that really would define the onset or end of puberty. So we still have those questions, and we still try to have a better answer on that. One of the things that I want to highlight as we're trying to answer those questions is that, you know, the task is difficult because there are very few randomized controlled trials looking into kids that they were treated with analogs and kids that they were not treated, because that's not an ethical study to do, right? So most of the evidence we have, they're based on relationship between height outcome and the age in which treatment began, and then height outcome is usually the difference between the predicted height and the actual height. Now, the way we do the predicted height is based on looking into that bone age, and that bone age reading can be quite subjective. You're always going to see us, we need to see the film, we don't need to see the report, because again, there can be big variation as to what our reading is and what the reading of the radiology is. So how do we decide to treat? How do we figure that out? So again, things to look at is, you know, when the puberty started, when those kids are coming to us, what is the rate of progression, how fast they're moving through Tanner staging, what is their growth velocity, what is the velocity of their bone age advancement. We still want to look into the adult predicted height. So again, we have to take under consideration what the genetic potential is as well, and then involve the family, right? So one of the things we want to make sure always when we're considering any kind of treatment in any patient, any pediatrics, is to make sure we're giving all the information to the family so they can make that informed decision as to what is best for their child. Now, a couple of take-home points. It is important to distinguish common variants of puberty from central precocious puberty. Again, you don't want to cause more anxiety with a lot of evaluation if that's not necessary. Central precocious puberty is about 40 to 75% pathologic in boys and compared to 10 to 20 in girls. So boys, you want to always make sure you're looking into them a little bit more carefully, always get that MRI. If you have progressive breast development over 6 months period and in a girl that is beyond age and they have a rapid growth, then you really want to consider early puberty regardless of their ethnic background or their BMI. You want to make sure as you're evaluating puberty that, you know, those kids need to come back to you pretty frequently, right? Either you're going to refer and make sure you follow up, they're actually follow up with a referral, or you have to come them back every 3 to 4 months. This is not a kid that you're going to see in the next well child check. And then in terms of, you know, how do we go around deciding about those treatments, this is a balance between benefits, risk, and cost. So we have to individualize, take everything under consideration in order to figure out if a treatment is suitable. I'm going to stop here to see if you have any questions.